Still good morning. Great. I'm glad everybody got some tea or coffee so that you can stay awake to my boring talk, but we'll see how things go. People are still trickling in. I wanted to get a sense of the room. How many are with a medical background? Dentistry, clinicians, nursing, public health? Okay, good. About less than a quarter, good. How about engineering backgrounds? Computer science, biomedical engineering, hard sciences, physics, okay. Humanities, social sciences, art, design. What did I not cover? I see some people haven't raised their hands yet. Education? What's in the humanities? Sure. Education? Okay. No other volunteers. Okay, so my background in a former life, I was an engineer. I was a software engineer working in IT consulting primarily, and then I went to medical school, and then I went to business school, and even further schooling in informatics, medical informatics at Harvard. So I kind of at the intersection of medicine, technology, and business, and currently at MIT focusing on the secondary analysis of health data at the same lab as Leo and global health informatics with this, and as well as digital health entrepreneurship. So my talk is on design thinking in healthcare. My outline for my talk, I'm going to set the stage a little bit, give a background on why healthcare is interesting, the various challenges and opportunities. Second, I'll touch on some common mistakes. Leo highlighted some. I'll reiterate some of those and touch on specifics within the development area. And third, I'll talk, the core of my talk is on the design thinking, the human-centered design for a solution and radical collaboration, and reiterate some final take-home messages. So to set the stage for a project, I'll just at a very high level talk about startups and the myth of startups. You know, you get a lot of news about unicorns and billion-dollar companies created out of thin air and then collapsing, you know, a year later. And specifically within hackathon projects, I wanted to temper just a little bit, bring a little bit of realism into the excitement of this event. I think it's great. I think we're going to have great outcomes, and there's huge energy, and I love the audience that we have right now and the participation levels. But just to temper the excitement, enthusiasm a little bit is that, you know, if you think about what projects are actually generated from a hackathon and continue beyond, you're looking at a very small number, around 5% of projects continue on beyond a hackathon. And, you know, even going beyond that, if you're thinking about startups, technology startups, 92% of startups fail within 3 years. So, you know, you're basically doing a shotgun approach and hoping that something hits, and sometimes it does, usually it doesn't. So just understand that when you're going into a project and build that into your risk calculation for whether a venture is actually going to be worth it, or just understand that you are going to be facing a lot of hurdles and barriers on your journey through this enterprise. And what actually happens, particularly in the US and the Silicon Valley, is you hit a lot of pilotitis. A lot of startups get a lot of enthusiasm and a lot of hype, but with very limited return on investment. And these are things that you have to consider within the field in general. So the next major point is that healthcare is challenging. You know, maybe about 20% of you raised your hand saying that you're in the medical field, and you probably already understand that. But for the rest of you with an engineering background or education background, I really wanted to emphasize that it's very difficult. So this is, does anybody know who this is? Okay, so Sherlock season 4 has just kicked off, and I just realized how much Colin looks like Sherlock. So it's pretty funny. Okay, so, you know, one thing I've heard a lot over the past 20 years is, we've had secure electronic banking since the 90s, even before probably the 70s. We're talking about between banks. Why don't we have a system like that in healthcare yet, right? That's probably very common. And, some of the implications are that business people are just better at knowing how to make things work, or doctors are just bad at business, or the government is at fault, We're all looking for Trump to fix things, but these are all completely wrong. I mean, maybe there's like a tinge of truth to that, but very little influence is actually driven by that. One of the core reasons is that medicine is complicated, right? The human body is complicated. There's so many different systems, interacting physiologies between genders, between races, and ethnographic backgrounds. And so, this is just a sampling. You can't even read it, and that's kind of purposefully done because medicine is very complicated. There's so much science and medicine behind how the body works, how it gets sick, and how to actually cure these. Like Dr. Selly alluded to some of that, but this is just to emphasize it. It's not just a simple factor of connecting and balancing credits and debits from an accounting balance sheet, right? So, which is what electronic banking does. You're just simply moving numbers around and making sure it's transmitted securely. Within medicine, you have to capture and understand all this immense amount of data. On the left is just all the physiological processes, some of the physiological processes within the human body. On the right side, a very basic medical protocol for a treatment of a single disease. So it can be very complicated, and this is the type of information that we're dealing with and trying to strengthen, and oftentimes just narrowing on one small piece of this. So, because of the immense amount of information that we're dealing with within medicine, it's both a science and an art. We're trying to build an evidence base, but as Dr. Selly alluded to, oftentimes it's an art where we're just taking a gut feeling from our previous experience, trying to synthesize all the information we have and make a healthcare decision. Where we are now, on this previous, we've got this little tricorder, which in science fiction says, we analyze the body and we can know exactly what's going wrong. But with the type of information that we have now, we just don't have that type of granularity and specificity with any type of diagnostic tool that we have. Here's an example of some of the signals that we do have. So within an ICU, you've got all these physiological leads and monitors on a person. This is probably as invasive as we get these days within the hospital. But with any of these signals, you're balancing the invasiveness of the monitor, so how closely you want the sensor to be on your person, versus accuracy, utility, and effectiveness. So something that's on the surface of your skin, you're not going to get a lot of. It's very easy to do. It's very not invasive. You're not going to be hurting the person. But the type of signals you're just going to get some electrical conductance on the skin, and the type of information that you're going to garner from it is just a bunch of fuzzy lines, and you're going to make a lot of guesses and interpretations, and maybe some gross estimates. But if you get more invasive, so like a catheter or like basically implantation, you're going to get a better signal, but then you're going to cause risk and detriment to the patient. So there's always going to be that trade-off with these type of signals and capturing these signals. So it's not just as simple as get as great information as you can, because if you do that, sometimes you can actually hurt the patient. So even with x-rays, you're exposing them to radiation and a health risk. And so what people get very commonly is actually increasing the risk of other conditions to that patient as you go along. So this is just talking about, you have the information, the type of training that a clinician has, when you have a student clinician versus a senior clinician attending, they have this base amount of schooling and data and information, but once you get to the higher, what you want is to be able to synthesize that information. And right now, computers, digital health can only help in the first, maybe second tier, but this is where Watson is supposed to be coming on, is synthesizing the knowledge and wisdom, but it's definitely not there yet either. So that's why getting this understanding of how clinical medicine works is going to be important in where you come in and intervene with your technical solution. In addition to medicine itself being complicated, the system, the overarching operations and legal framework and policy is very incredibly complicated. So this is the US healthcare system, and these are all the different players, stakeholders that impact it. Don't try and read it, but just know that there are so many different people and groups that have an impact in the US healthcare system. And so I'll get to some more of that. And more specifically, I wanted to touch on the global health challenges. So low and middle income countries, rural medicine, they face challenges that larger urban areas do not have to encounter. So the specific challenges include the rural nature of both the patients and the communities. So they have to travel large distances just to get some primary care. And then if they go into these areas, the coverage, the specialty coverage is much more sparse as well. So rather than, for instance, Boston having the highest density of clinicians in the world, you're going to have one clinician covering hundreds of miles, for example. And so the patients have to travel a great distance, and this exacerbates any type of condition that they might have. Second is the rural infrastructure. So just by being infrastructure, meaning the distance, but then also the poor roads that they have to travel actually, so it can take them weeks to travel just a couple miles rather than the couple minutes it might take in a highly developed urban area. That includes electricity, power, and other types of infrastructure limitations. The systems, the hospital systems and the clinical environment within these rural areas are also weaker, so that they have, rather than large academic hospitals and multiple cancer centers within this area, they have primary care clinics or community health centers to provide care with less resources, less human resources, the clinicians, as well as equipment resources. The low and middle income countries and rural areas also face a disproportionate disease burden. So in addition to all the common conditions that we have, they face specifically diseases of poverty resultant from the poor infrastructure. So they have poor water security, so they face hygiene and water purity issues, malnutrition because they lack access to foods, infectious diseases usually fester around these poor areas, and natural disasters disproportionately impact them as well. So while an urban area will have a fire department, ambulances, and everything on site to help these people in the rural areas, there are much fewer rescue workers, and that's why the economic and health impact in those areas is so much greater when there's a natural disaster like a tsunami or an earthquake in those areas. In addition to this disproportionate diseases of poverty, they're also facing diseases of wealth, or the Western disease paradigm. So they're facing the same health conditions that wealthy countries face, partly because of increasing access to sugary foods, so poor diets, diabetes, cardiovascular disease, and such. So not only are they facing the diseases of pestilence, but also these things that we also face in the U.S. So there are growing disparities for these regions. So the poorest of the poor, the most vulnerable populations, they're unable to pay, and they don't have access to standards of care. On the bright side, the very, very lightly bright side, is that potentially yield the biggest impact for low-cost mobile technology and innovation. So this is where we're coming into play with the mobile technologies, the ubiquity of mobile health, ubiquity and portability of mobile health technologies. So, Leo highlighted the size and cost of a hard drive shrinking, but then on the other side, on the computing power side, if you think about the Cray power computers, so supercomputers, Cray power supercomputers from the 1980s. I don't know how many of you were alive then, but they were giant machines that filled the room, and they were the most expensive, millions of dollars, and maybe there's one in a university academic center. Now your smartphone has more processing power than that giant Cray computer. So with that understanding of the background and the challenges, there's a lot of opportunities for innovation within digital health and global health. So I started to talk about this, but the benefits of mobile health include democratizing access. We can overcome infrastructure limitations because of how portable these smartphones are. We've got some just sitting in our laps, but sitting in our pockets. With improving batteries, we're going to be able to do more things in these rural areas that have inconsistent power access. Improved diagnosis and tracking. We're able to use the computing power to improve decision support, disseminate protocols and guidelines, and really hopefully be data-driven, using this digital data to crowdsource data, and then also foster network effects for building the community and learnings. Don't read this. This is just saying that there's a lot of different applications within healthcare, mobile health, including education, data connectivity, clinical tools, decision support, et cetera, et cetera. My talk is not emphasizing any of these, but just to say that there are a lot of different applications within mobile health or digital health. But the bigger question is, why now? Why you? Why are you here in this room? Why are we here in this boot camp? And the three primary reasons I find are, number one, social justice. Healthcare, I feel, and many others feel, is a human right. Everybody deserves access to equitable and standard healthcare so that they can live to maximize their lives. And we have an opportunity within digital health, to actually improve lives. So you engineers who have a lot of options of, do I go into finance, make a lot of money? Do I go into a tech startup and start my, create a new WhatsApp or Facebook or whatever, Google? You have an impact, you have a chance here, while those are great tools and they have great impact to social justice and such, but here you can make a direct impact in improving lives with your skills, your discoveries, your innovations. Second, at least from an engineering perspective, we like a technical challenge. We like to solve something that hasn't been solved before and to push the limits of what we know and what we can do. So I think the cognitive complexity of healthcare is actually very attractive to some. So a lot of engineers like to solve these problems. They don't want to just keep reproducing the same broken wheel, but instead, let's try and solve these really difficult problems that others are too scared to actually face. So we have a chance to create and solve new solutions. And third, from the MBA perspective, there's a lot of business opportunities, right? So finance, stock trading, you're looking at innovating and trying to make money on milliseconds or fractions of a milliseconds to do trade sooner. But now, mobile health, global health is a new frontier where there's a lot of change in government regulation, so there's a lot of opportunities to make money. And then healthcare is seen as a human right, but then it's also something that people are willing to pay for. They want to live, they want to get better, they want to feel better, so there's a unique supply, demand, and willingness to pay balance here where people will pay to improve their lives. And so it's just a matter of figuring out how to take advantage of those opportunities. If you can't hear me, please raise your hand, or if I'm talking too quickly, I'm happy to change my speed as well. I have a tendency to mumble and talk really quickly, so you've probably noticed, so I take no offense if you raise your hand. So the second major point is to touch on some common mistakes, what we see repeatedly, right? We've got a lot of cool technologies that we love, we want to try. This presentation, this specific slide is actually a couple years old when Google Glass first came out, and you got the HoloLens, you got a lot of VR technologies. But how many of you actually have one, like an Oculus Rift? Not many. So, and are there actually practical applications? I know so much money went into Google Glass funding for clinicians last year, the year before that. Nothing's come out from them. It's very limited use, very limited utility. And while technology is constantly advancing, you've got the Moore's law reducing the number of transistors, or increasing doubling the number of transistors on a processor, so technology is constantly booming. But the actual thoughtful applications of technology is sometimes lacking. Maybe we're not actually innovating in the right area, creating the right tools that are actually useful. Okay. So even within health IT, we've got a long history of implementation challenges that we've already identified. We know that technology is a problem, especially cost and reliability. We're just getting there now. In the old days, it used to be a Palm Pilot for those who are old enough to remember. Now we're getting to Android 2.0 versus Android 6.0 is like light years ahead. So it's constantly evolving, but there's still challenges. The various systems, I'm just gonna, don't try and get all this down. I'm just highlighting that there's tons of challenges within implementing healthcare that we've already identified. Interoperability is very key, and regulation of policy has problems. And we've already identified there's already a large evidence base of unintended consequences. Why do these mobile health and digital health solutions continue to fail, even though we're putting so much money into this? A lot of it's focusing on the data, the workflow, communication, etc. So we know that there's a lot of problems. We know that there are common mistakes, but somehow we still continue to make these mistakes. And I just want to highlight 3 reasons why. Number 1, it's too often that we do technology first. We had the question that was kind of obliquely related to this. You've got a new technology, you start with this cool discovery, science discovery, and then now you want to find a solution to it, right? So you want to find a problem that applies to that solution. And this is too common. I mean, Leo kind of alluded to this. There are success cases of this, right? So you've got the business case of 3M creating Post-it notes. It was a non-sticky glue. They had no application for it, but then 5 years, 6 years down the line, it became a huge billion-dollar solution. But you can't go for that moonshot within healthcare all the time, right? You're going to luck out somewhere down the line. Somebody is going to do that. But if you're talking about probability, chances, and actually making a logical step towards the innovation, is you want to start with the problem first rather than starting with the solution. So don't try and take this technology that is this science technology and just try and shoehorn it into, in our case, rural health, because maybe it's not the best application. Instead, start with the problem, what the real problems are in that particular environment, and then try and think of this universe of science and technology advances, which ones will actually improve that problem. Here is just a basic example. I like to do silly illustrations. So in the case of making music, you sometimes have a metronome, and it's a very useful tool. This thing's been around for, how many people know what this is, a metronome? Some people don't know it. Okay. How many people play music of any kind? Classical music, modern music, some guitar, violin, piano. So this is a metronome. It keeps very simple count. It's very accurate. It uses a pendulum system to basically count out how many beats per minute. You can range from like 60 to 120 to 212, something like that, beats per second. And musicians, or especially learning musicians, use this to be able to accurately keep pace for the music. So basically, it's a rhythm box to make sure that the music is on pace. And this thing's been around for hundreds of years, maybe. And this is what an engineer might design, while the thing on the left, the metronome, is, maybe $20. The one on the right might be $300, and it uses digital equalizer and stuff. But it does, if you're just looking for keeping the same rhythm, the one on the right is just the costly alternative to the one on the left. And Leo actually highlighted a clinical example, which would have been better illustration in this case, of the malaria. So using a laser to zap a mosquito versus using a mosquito net. Mosquito net is $1. The laser is tens of thousands of dollars and actually not as effective. All right, so this is all around using technology, or going for technology first, trying to use technology, and then trying to shoehorn it into a problem versus starting with the problem first. So mistake number 2 is adding work. Coming from an engineering perspective or technologist perspective, I love being on the leading edge. I love picking up new technologies first, and it's worth the effort for me, like to get the newest app and try it out. And I know James has a Fitbit, and he was telling me about all the various cool things that he's been able to analyze and discover, and he's going to talk about that tomorrow. But we like it, but the majority of users don't have the time to take that on. So if you think about clinicians in particular, while the adoption of EHRs have a lot of benefit, we want to be able to do it because, if we think about the secondary analysis and the utility of that, both from a data science perspective, but then also a continuity of care perspective, there's a lot of benefits to implementing EHRs. However, the way that they're currently designed, they add long hours of work to those who are already overworked. You have clinicians in the hospital, 10, 12, 14-hour days, and you're adding 2 hours of paperwork at the end of that. They don't have a lot of time to actually adequately document within their EHRs. So many technology solutions, digital health solutions, add work. They ignore workflow implications, so they just think, okay, I want to capture this data, so who's actually going to capture that data? How is that going to be get into the system? And so many engineers have the fault of not getting the input from clinicians and making sure that you have clinician advocates on your team. And what happens is that clinicians or your users are going to find workarounds. So for clinicians, they're going to be capturing inadequate data. They're just going to be checking off boxes just to get the system done rather than actually leveraging and taking advantage of the powers of the EHR. So this example is they've got a Fitbit and basically using the metronome in the previous example to swing back and forth and say that you've done all this immense exercise while you're just sitting there watching it go. Mistake number 3, which Leo talked about earlier, is you neglect outcomes. You're not focusing on quality improvement. Some of this is just pilotitis, where you just want to start something just because it's cool, but then it stops working. It's not sustainable because it doesn't actually make an impact on clinical care and clinical outcomes. So always focus on improving lives, improving quality of care, rather than just focusing again on the technology or wouldn't this be great, or who might actually, or trying to sell it as the next generation of technology. Always focus on creating an innovation that impacts quality improvement. The next section is going to be talking about design thinking, so the key point. This quote from Tim Brown, he's a little biased, but the point is that design in itself is too important to leave in the hands of designers. You want everybody to be involved in the design process. It's not just a matter of graphical aesthetics, handing it off to designer, giving them a design brief and getting it put back. It's how everything fits together, including usability and workflow. So it's not how things look, but then that's an aspect of it, but who uses it, how they use it, and how do they interact with the data. So another aspect is UI, user interface versus usability, or UX. Unfortunately, for those clinicians in the room, you've seen many forms and systems like this. Medicine is replete with bad UI and bad UX, Basically, traditionally, the traditional way of designing an EHR was simply replicating paper forms, which in itself were not that efficient, but they were optimized to capture data using a pen and paper. You know, usually doctors just cross and check off straight down the line and sign off on the paper. They only focus on maybe 10% of the page rather than the entire form. And so many EHRs are like this. And, you know, checking something off with a pen takes a fraction of a second, but if you're using a mouse, especially more senior clinicians who aren't familiar with a computer, can actually take 3 minutes to capture data or even longer. So this is not a usable interface for many clinicians. Within design thinking, the emphasis on user-centered design. I'm sure some of you have seen this illustration. You can probably Google it. It's very common and popular. Basically going through that there's a lot of miscommunication and misunderstanding of what people want, and what we want to do is actually get into the core of what the customer user actually needs, and that's why the design thinking process is crucial and important to implement, so that you quickly get to the bottom right rather than designing and deploying something that's unusable. So there's a standard design thinking process. There's many different types of processes. I'm not going to highlight this in explicit terms. There's a lot of design thinking courses that dive into it. But just really quickly, there's empathy, defining the problem, ideating, and trying to brainstorm solutions, building prototypes, and looping back to ideate and test and things like that. I'm going to highlight a couple sections on this, but you know, the core point of design thinking is to bring the various groups together, and that so your solution sits in the center here, right? So that it's overlapping the business utility, business viability, the desirable of the product to the users, the feasibility of the technology. For us, we'd add a fourth circle of clinical impact, and through this process, hopefully you'll get in that center, because if you're not in any of those, the technical solution has a much more higher chance of failing. So the main points about the design strategy is these 4 points of radical collaboration, bringing together a lot of different backgrounds, which we're doing here at this hackathon and bootcamp, people with a lot of different backgrounds so that we can really troubleshoot the problem. And second is framing the problem, really understanding what the problem is rather than going from assumptions or your own perspective. You can get a lot of different perspectives to better understand what a viable solution would be from an, I think I might touch on that later. Third is the brainstorming and general ideas. Too often we start with this design process with our own convergent assumptions and we replicate something that already exists. But with this design thinking process, you specifically want to facilitate divergent thinking, so you brainstorm as many ideas as possible and converge on the best solution. So we want to urge people to bring in as many different ideas. So if you're not an engineer, if you're not a clinician, we value your input, because this will allow us to think more creatively about what the solutions are. And we want to be able to think laterally and brainstorm as many different solutions as possible so that we can hopefully test them and converge on a novel, innovative solution. In practical terms, things that you might consider applying during the hackathon or to your projects later is to, these are some, I think there are 3, there might be 4, I think there's 3, specific things that you should specifically do for when testing your solution. Number 1, stakeholder analysis. Understand who the various stakeholders are for your solution. Number 2 is workflow integration, making sure that it integrates closely with existing workflows and just doesn't disrupt it too much. And 3 is prototype validation. So stakeholder analysis is who will interface with the technical innovation. It's not just the end users. Particularly in medicine, because the beneficiary of the healthcare, of the solution, who ultimately we hope will be the patient, is not usually the end user. So you have to think about who's actually going to be using the tool. There are some innovations that really focus on patients and having them capture their data or to educate them. Some tools interface at the care team, the clinician, nurse, or community health worker to facilitate their efforts. There's also organizational benefits, so hospitals will often deploy digital health solutions so that they can improve their efficiency or care coordination and things like that. So when you design your solution, make sure you think about as many different stakeholders as possible, specifically because within healthcare in the US and probably in many, many other environments as well, is that the users or the beneficiaries of the system is not always who's going to be paying for the system. So you've got government or insurance payers, but while the beneficiaries are the clinicians or the patients. So also think about the deployment of your solution from the various systems. Earlier in the talk talked about the various, all the intersecting people, but also think about your deployment, while you want to think locally, like within the village or community, there's also larger organizations at higher up who might actually benefit. So while you might want to deploy something in a community health center, the regional government might actually be a larger stakeholder, more impactful stakeholder who might want to fund or support the organization operations. So by doing the stakeholder analysis, you can really focus on what will drive the adoption of the solution and identify what barriers there are. And as well as identifying who some key advocates will be. So a lot of times within a digital health solution, if you're an engineer, you want to bring on a clinician advocate, somebody who will really voice their perspective and then also communicate the benefits of your solution, be able to speak the same language to their decision makers. Workflow integration, this is the chart earlier about how complicated the systems are, but the whole point is that technology, as Leo emphasized, is only a discrete component of the whole intervention. You want to deploy the technology, but make sure that you're closing the care loop and focusing on quality improvement so that the technology doesn't disrupt the existing systems and workflow, but instead foster efficiency and usability and doesn't add work. Third is prototype validation. So rapid iteration of a possible solution so you can have proof of concepts and validate any early hypothesis as early as you can so you can adjust and pivot your solution. To answer the earlier question during Leo's talk about how to get public health, I think there's a couple points related to here. How to get the public policy people on board is two aspects. Number one is the stakeholder analysis, bringing on business people. It's a communication problem essentially, right? So you've got to be able to have somebody, communication and business development problem where we're always focused on the research side and making sure the science is strong as well, but you need to be able to communicate what your actual solution is. And then in addition to communication through business development is this rapid iteration. Get some evidence really quickly. Don't just go on the theory, just say, we think, give us $1 million to create the solution. Make sure you have some evidence, some rapid prototyping, proof of concept to say, we did this initial problem, we have this initial test, and we validated our hypothesis, so now we deserve the funding for this next round. So to reemphasize the design challenge, healthcare is complex, it's very challenging. We have to focus on clinical quality improvement, we have to integrate with various processes, and we have to foster workflow efficiency. So some take-home messages. We emphasize co-creation, teaming with partners on the ground who understand the local context. You can't just take what works in Boston and try and transplant it to Khon Kaen. You have to make sure that you work with the local university, the local clinicians who better understand the users and patients. So that you can so you can also understand what problems to solve, right? So what's actually big in Cambridge, Massachusetts is different from what we want to solve here. So same problems, different systems have a different implementation. Second is collaboration, working with various different backgrounds, so that we really want to promote multidisciplinary teams, engineers, clinicians, policy, social work, education, design, to come together to build a holistic solution, to understand how to solve the problems with holistic solutions. So some various collaborators that you might consider. Clinicians obviously are important to understand the medical side. Public health is actually very important as well, because you want to evaluate and monitor the solution. Too often we have clinicians who are only focusing on delivery of care, delivering as much care as possible for the patient, but the public health expert should draw them back a little bit and focus what's the most effective and utilitarian deployment for the resources that we have and which will make the biggest impact. So a clinician will, taking again from the health, I'll skip that. So third, I talked a little bit about the business aspect, but they're going to be important for the sustainability, the marketing, the communication of your solution. So while it doesn't have to be an MBA, but it has to be somebody or a researcher or engineer who's facile in that area so that they can put together proposals and respond to RFPs to actually get the funding, to be able to communicate to the decision makers, communicate to the public policy makers or the foundations about the importance and impact of your solution, but then also develop new partnerships and relationships with governments, local, state, other NGOs to actually partner and use your solution. So it's actually important to bring it. And then social workers. Because so much of healthcare, especially rural medicine, primary care, rely heavily on systems rather than rather than clinicians, and the impact of any solution really ties up to follow-up and adherence. So, doctors see patients for such a limited time in the hospital, but then they go out to their families, and this is where actually the follow-up and adherence to treatment recommendations is actually more important than bolstering the primary care workforce. Second, another aspect we focus on is capacity building, making sure that we have locally derived innovation. It's great that we're here. We love coming here. It's been amazing to share and collaborate, but for the next generations to continue this, to continue the momentum, and to really build on the capacity we have here, we have to have the innovations and changes come from you guys. To solve the upcoming problems, the next iteration of the next generation of innovations. So again, the caveats, hackathons are great, but with limited tempered expectations. It's great for learning, exploring, and iterating really quickly. And this is what we want to encourage you guys to explore and network with each other. And the objective, the long-term objective, is to succeed beyond this hackathon. We don't want to just focus on what your project is here, but build communities, network with each other so that you can actually learn from each other and continue to explore the next generation of innovations. So I'm going to close with just some characteristics of a successful team. Number one is collaborative. So you've got complementary skills. You've got an engineer. You've got medicine. You've got education, social workers, public health policies, people all together on the same team, working on a holistic solution. Because medicine is so complicated, it crosses so many systems, so many stakeholders. Second, it has good leadership. So it doesn't have to be a single person, but it has a group leadership, but you need good leaderships in order to identify when to pivot, when to change course, when to persevere, and actually when to give up, right? So within business, we've got something called the sunk cost fallacy, where we've already put billions of dollars into this system, so what's another $1 million to actually see it? Sometimes you just have to cut the cord and say, this is a waste of time. Experience is important, and this does not necessarily mean age, but experience in the particular area you're going to be targeting. So if you're going to be targeting a rural health solution, it doesn't necessarily mean to get the orthopedic surgeons on board, but rather the residents and the clinicians who are on the ground within the rural health area to provide the skills and insights to actually innovate a solution. Another aspect is empathy. You really have to listen and learn. Get the feedback in from your design groups, feedback from users, feedback from your data, and make sure you can adjust and adapt your solution. So to both your customers, but then also your teammates, understand, so if you're an engineer, hear what the clinician is saying about whether it's actually going to solve the problem. If you're a clinician, listen to the engineers about whether this technical solution is actually feasible, right? Okay. And finally, execution. Execution is actually probably the largest indicator of success of just getting things done. We have so many people with brilliant ideas, great ideas, but what it ultimately comes down to for the success of any startup and enterprise is actually just getting things done. You know, do things, fail fast, identify what actually works, pivot to improve it, and you know, meet deadlines, deliver product, and solve problems. So for any draft proposal that you have, any research project, you have to get it done in order to publish and go to the next stage. So in closing, you know, now it's your turn, you know, to try and make a new innovation, make beautiful music, and et cetera. So our line is that geniuses are everywhere, and let's nurture them. So this is you guys. It's a bad picture, but this is what we got. All right.